little bit behind, so we might cut it just a little bit, cut the discussion just a little bit short. So.
Oh. Yeah, for sure, man. The stage is nice. You want to put your foot up on the little scooter? It's nice, man.
You want to ride a scooter?
Yeah, I'll rent it. I'll rent it out.
Joel, you want to open this up?
Yeah, let me start out. I want to be provocative here, but President Reg told me I had to be. But this is directed to Brant, but also to the others purporting something else to replace the Nissen funapplication. And Brant, why do you think the other companies aren't interested in comparing it, and particularly the links? And the reason I say that is I've heard them say, well, they're going to lose. How do they know that? Because it suggests maybe they don't think their device is that good. Secondly, when it comes out commercially, or at least in the community, the implication is it is as good as the Nissen funapplication, or maybe better. And third, the problem I have with these non-specific complaints, like gas bloat and dysphagia, is that, they are very subjective. Therefore, to only know what the rate is, you've got to use the same measures and compare it directly. So I think this is a bogus. I think they're afraid to compare it directly with the Nissen, because the Nissen, over a 5-year period of time, like you alluded to, maybe I've been blessed in the centers I've been at, my surgeons do good Nissens. I just don't think they're going to hold up. And I'd like to hear what the other ones, particularly Luigi with the with the links, but Brant, since you were supporting the Nissen funapplication.
Is this on? Well, when I talk to companies about this topic or other comparisons, so, other examples, if you go to Steve's topic of mesh, which mesh is better, they don't want to compare those things either. The response I tend to get in private is these are high cost, high risk studies for them to be a part of, because if there is the impression in the community, even in large pockets of the community, which I think it does exist for the links, that it is as good or superior, then all they can do is lose. They figure they're unlikely to, they have to be fairly superior to win and capture the whole market. So it's an expensive endeavor, and if it comes back inferior in significant number of ways, then they have lost. Now I'm not here to tell you I think that they would lose, be the same, or be superior. I don't know. I just think that it would be nice, as you I think are saying, to know the answer and to be able to compare it, and be able to compare it head to head with the same questionnaires and the same randomized patients and so on and so forth. Otherwise, it's one group saying I did 50 patients or 100 patients and none of my patients have bloating, and another group doing a different procedure and so on and so forth. And it makes it nearly impossible for me to sift through the truth. But that's why it's my opinion. And I haven't asked now what Medtronic owns. J&J owns the Lynx device, so you have to ask them, I guess, directly whether they'd be interested.
Never going to happen. But, Joe, what I would say is that, everything has a failure rate. There's no perfect thing in medicine, period. For me, I do both, but I get the patient's input. If you really, really, really want to stop reflux, the patient comes in and says, you know what, I am so done with trying to sleep in my recliner, having regurgitation, watching what I eat, or this or that, and I just want my reflux gone. There is nothing that's going to be better than Nissen, period. The Lynx works, but it allows reflux. If you overeat with a Lynx, you're going to have some reflux. It's designed to vent. The Nissen, as Red showed you, will not vent. If the patient's like, yeah, I can deal with a little heartburn every once in a while, but I don't want to deal with, inability to belch or vomit, Lynx is perfect. So you got to select the patients and let them help you select them a little bit, in my opinion.
I have a comment. For the sake of full disclosure, I'm I'm Joel's surgeon, so I don't know if I still feel warm and fuzzy or a little bit creeped out that he's so possessive of me. But what none of the speakers today, including myself, none of us actually looked at what the economics of all of this is. And the truth of the matter is that all the stakeholders have a different economic outlook. The patient has a particular one, and if you're paying for something out of pocket versus something that the insurance company is going to pay for, you're going to think about that differently. The insurance companies have a different economic outlook about what their time horizon is. So, and similarly, the hospital and even us. I mean, when we do a procedure, we kind of make the calculation: is the time I'm going to spend doing this procedure worth the reimbursement that I'm going to get for it? And we actually need to be more explicit about what the economic risks and benefits are when we talk about these treatments. I would tell you, I would hate to be a new device company and try to get something paid for. You would be better off trying to make a better Foley catheter and come up with something completely innovative.
Rena, do you have any thoughts on this? I ask you because the concept of individualizing also makes it very hard to have any head-to-head comparison here, because the very theme of Reg's presentation, for instance, was that different physiological aspects more or less channel people toward one approach or another, similarly with outcome metrics.
Yeah. I think if we were thinking about a study design where we were comparing different interventions, perhaps stratifying the patients according to what we think would be the appropriate clinical patient selection for that patient. So very much what the other speakers spoke about today as far as transverse versus axial, hiatal hernia and LES pressure, and perhaps stratifying them in certain groups and then doing head-to-head trials within those groups. Maybe that would be more clinically meaningful rather than just doing a general.
But it also
RCT.
gets more and more challenging.
Absolutely, yeah.
Microphone? Oh, sorry, Trip.
Thanks. What a great afternoon. Several speakers mentioned an experienced foregut surgeon. So I want everybody on the panel to weigh in very quickly what that might look like to him or her. And you can't obfuscate by saying that maybe that's for the American Foregut Society to define. I just want to hear what your all's impression are. What does that mean to be an experienced foregut surgeon right now, today?
I'll start. Oh, go ahead.
I'll start out and say,
Gray hair.
What about no hair?
you're out. There's a volume requirement, I think. I think from one of the slides you saw earlier on bariatric applications, there's clearly a relationship between volume and technical skill. So I think you need that. Secondly, you need to have more than one trick in your bag. Because if you only have one trick in your bag, you're just going to use that for everyone. And I think these days you need to either have those options or at least be willing to refer out. And thirdly, you need to know the physiology. So with rare exception, like if you work at Northwestern, where they kind of dictate to you what to do thanks to their supreme expertise, and I'm saying that a little in jest, but a little in truth. Those guys know what they're doing in terms of working up a patient and referring them for surgery. But across the board, you really need to know the physiology. So I think those are the three things for me.
I've got to know you. I've got to talk to you and know your philosophy. I need to get patients referred to you from me, saying, I don't think these people need to be operated on. Could you work them up for me? And I need to have some idea that you do these procedures on a regular basis and that you don't always operate when somebody tells you to.
And ideally, you're not seeing them back, because if there's a complication, the surgeon's taking care of it, not sending the patient with some trouble back to Phil or another gastroenterologist. You got to own your complications and fix them.
Or at least work with somebody who's willing to handle them for you.
Right. The volume thing is challenging, because I think you can be a very good surgeon at a lower volume, so it's hard to set a number. But it's a bit like cardiac surgery. If you're doing one CABG case a year, you're probably not very efficient and good. So there is a relationship, although defining a number is tough. But there, if you're not doing it often, you're not going to do it as well.
And conversely, you can do something badly very often.
That is true.
So I'll just add, Trip, if we're talking about metrics as to how you classify someone as an experienced foregut surgeon, in GI and in endoscopy, we've done a lot of work with competency, so developing metrics and looking at competency learning curves, and so that may be a starting place as well.
In an ideal world, it'd all be about outcomes, but few people track their own outcomes to any significant degree that probably would satisfy the outside world about that.
But that is key, that you need to track your own outcomes.
You absolutely do. If you're not tracking your own outcomes in a very honest way, you're a bad surgeon until proven otherwise.
Yeah, I agree. I mean, in colonoscopy, we're tracked extremely stringently in terms of all the parameters, cecal intubation time, withdrawal time, polyp detection rate, and so on. And that's moving to how we look at the esophagus and how we assess Barrett's. So it should be no different for the foregut surgeon.
I think that's a reasonable flavor for the response.
So I'm not on the panel, but I'll just add to amplify on that. So we are looking at that in the surgical world as well. I mean, the concept of defining proficiency according to objective metrics that both are for the performance of whatever procedure there is coupled with the postoperative outcomes. I mean, that it's happening, but it's happening much, much more slowly. It's a lot harder to get that critical mass of data together to really translate one to the other, but that is happening in surgery as well. So Paresh Shah from New York. This was a fantastic afternoon. I agree with Tripp. I wanted to just make a couple of comments. First, Reg, your talk is spot on. I mean, the idea that GERD is not one disease, and Joel, to your question, one of the reasons it's so hard is because the spectrum of the phenotype varies, and frankly, the spectrum of the underlying disease process varies. Some of it is crural, some of it is LES, some of it is patient, some of it is supratentorial, and you got to look at all of them. And so you can't take every treatment head to head. But one comment that you made really rung true for me, which is defining the right measure of success, which is we've fallen into this trap over the last 30, 40 years. If we come up with something surgical, it has to eliminate the need for medicine. And I think that's a complete fallacy. And we're seeing that now. Look, we've already experienced that in coronary artery disease. We've experienced that, we're experiencing that now in the world of bariatric surgery, where it's not just about the operation, that there's multimodality. We're experiencing that in cancer care as well. So I think that's an important concept. So I just wanted to congratulate you for that. I thought that was fantastic. Ken, I wanted to elaborate a little bit more on some of the stuff that you're doing, some really avant-garde stuff around interventions, your resection and plication approach. Can you contrast that to what Haru Inouye is doing with the arms therapy, and look at what your experience has been versus what his has been reported to be? We're starting to toy with that concept as well, and I'm just not sure, we've seen dozen different potential therapeutic interventions for reflux disease already today, some of which have a long history with not really great data, some of which have very little history with more data, and stuff everywhere in between. So I'd just like to hear your thoughts about ARMS.
Yeah, Haru Inouye, a good friend, he's the inventor of POEM, and so he does a lot of EMR and ESD, and he found that when he was doing serendipitously, he had done some ESD in patients with high-grade lesions in the cardia, and lo and behold, their GERD got better because after a complete mucosal resection, almost 360 degrees or at least 180, with the scarring, the G junction became tighter and less compliant, so GERD got better. So that was called ARM, and so anti-reflux mucosectomy. So people who saw that said, okay, but who's going to be doing ESD, for GERD, right? In the States. And so, but can we take that concept and control it better, combining it with suture, maybe suture alone, or ablation and suture, or simple EMR instead of ESD and suture, so you can control the scarring and control the closure so you don't get overtreat and cause a stricture. So again, I think that because it's not doing any of the mechanism that we've talked about for the proper anti-reflux procedure, but there are situations where altered anatomy won't allow you to do any of the standard anti-reflux procedures, and I think that's where these procedures may come in helpful.
So I must comment that all of these procedures that create a defect to correct a defect that are not evaluated prospectively are a mistake. And if this society is to truly succeed, when someone has a good idea, please study it and don't just do it, because these are strictures to us. And you're creating a stricture to stop GERD. It will stop GERD. If it's not a real stricture, I get it, but let's understand that and not publish papers that are creative and intellectually logical and maybe genius on the part of the surgeon or the endoscopist. But let's understand what they do, please, so that we don't end up with a quagmire like we're debating now with POEM, where we don't quite understand reflux in a very, very good procedure for achalasia. That's my comment.
Microphone on the right, we've ignored you over there. That's you.
Ken, with your one-stop shop, and you're scoping these folks for reflux symptoms, and you find a pristine esophagus, and you put in your Bravo pH probe. As a gastroenterologist, I'm curious, what percentage of the time are you finding reflux in those results, and are you seeing so much functional heartburn?
Yeah, so I would say maybe not the 40%. So if you look at Tom DeMeester's data, 400 out of 900 had the dynamic failure, essentially a normal anatomy. I think in our experience, it's more like 20-25% of patients, NERD patients, no esophagitis, LES appears competent, there's no hernia, retrograde, and below CO2, and it doesn't open up, and it's truly a Hill 1, and you do a manometer, a 48-hour, 96-hour wireless pH, and it's above 6%, and it's predominantly upright. So in those patients, we find them, but they're about 20%.
We'll take Dr. Spector, and then I see you guys, so you'll be next.
Yeah, thanks, Peter. Great session, loved it. I spoke with Luigi a little bit about this, but I have a question regarding ineffective esophageal motility and how it relates to our choice of patients for magnetic sphincter augmentation. So, it was a lot of patients with reflux disease have ineffective esophageal motility. And it was always a wonderful idea to try to tailor the operation around the motility abnormality. But short of having absent contractility, it really hasn't worked out that well. Most of the high-quality studies on the issue haven't really found that the pre-op manometry findings make much difference to the outcome.
Quite the contrary.
Yeah, okay, fair enough. So are we being too rigid with our criteria? Reg, I liked your thing with the oomph thing, but do you have data that if you have oomph, you do better?
We just need a better metric. Oomph.
Well, in my opinion, as long as you don't do a Nissen fundoplication in those patients with a real severe esophageal motor disorder, you don't get any trouble in doing a toupee fundoplication or even the MSA. I think that in most patients, an ineffective motility disorder is induced by severe reflux. So we have seen also in MSA patient that so-called ineffective esophageal motility can reverse to normal after correcting reflux.
Thank you.
Just to follow up on that. So one of the issues we have is that standard manometry is super sensitive. How many of us swallow 5 cc's at a time? And so it's going to pick up a very very low threshold. Most of the time when we swallow, it's a bigger bolus, often warm fluids that generates higher peristaltic pressures, or semi-solid stuff. So I think that we've used that threshold in our studies, and I think both John and myself and some others who are keeping track of our patients have been pushing that bar down a little bit, trying to understand where that limit is, because we need to know that. But there is certainly, in my experience, a limit as to how far down you can go before you do start seeing dysphagia with an MSA. But I don't know what that is. I just understand the sensitivity of motility in terms of what we're talking about in terms of normal behavior.
John Pinnings. These are terrific talks, and particularly loudly resonated with Dr. Bell. And one of my concerns as just a practicing surgeon is that there are really great new technologies that we should be applying to the patients on an individual basis, but can't because we have all these insurance restrictions out there. If it's reflux, it's a NIST or nothing, and that's very frustrating. So my appeal would be, could this organization maybe start or be a authoritative voice that we could somehow submit issues so they could feed back to these insurance companies to get us moving in the right direction?
The short answer is yes, if we just knew how to do it. We spent an hour talking with some of our industry relations yesterday, and that was what we spent the whole hour on. So yes, it is a very significant source of frustration. Yes, it's on our agenda in terms of how to best approach that down the road. Absolutely.
Vicky?
Yeah, hi. So just a quick comment. I think we're starting a new society and we're trying to find out what we're going to do. And I think this is an issue that we have seen time and time again, that we are looking to pick one winner. And that's setting us for fault, so that there can only be one surgical therapy. And the same thing in our guidelines, that we are trying to go and look for one truth. And there are multiple truths which could be the right truth. And that's where we are going to set us for problems by going into these, talking about a comparative trial and trying to find one truth. I think it's okay to have multiple therapies that are effective and safe. There may be different issues. And the person that's going to go and try to sort of decide what's the right therapy is the patient. And that, once again, going to the guidelines, it's actually quite surprising that patient advocacy and patient choice, which actually, if you look at the FDA and some of those things, is becoming a prominent feature, is prominently missing from our guidelines. We have surgical guidelines, we have a gastroenterology guideline, but patient choice and patient advocacy is missing. So I think we can learn from other specialty, bariatric surgery and other, where multiple therapies are okay to have in the armamentarium to treat a spectrum of disease, and they're not going to be all the same. So there's just a comment and maybe a response.
With all due respect, you can't grade evidence for patients, for patient advocacy. You got to put them in a different place.
I do have actually a comment about what VK said in the previous speaker. There are probably many of us in the audience who are old enough to remember when insurance companies did not pay for breast reconstruction after mastectomies and didn't pay for bariatric surgery because they were all considered elective and not really taking care of a problem. What got that changed, particularly in Michigan, where I'm from, was that the patients went to their state representatives to advocate for themselves, and it took state legislators to essentially to dictate to insurance companies that these procedures were in fact necessary and they were going to pay for them. So evidence is great, but eventually you can have the best evidence in the world out there that meets the highest standard, and then insurance companies are going to go to their default position of saying, well, it's not going to be a covered benefit. So if you really want to change it, it has to be done on a legislative basis and not necessarily based on overwhelming evidence.
It's a brief question to the surgeons on the panel. Somebody asked the question, what defines a good foregut surgeon? And the definition could be maybe related to volume, could be related to technique or combination of. But when you look at the good foregut surgeon and you look at their procedures, toupee in special, there are so many variations in the technique that between a Nissen done by good surgeon A and good surgeon B, and even more so for the toupee, that how can you expect the optimal results, because we kept talking about trying to get the best outcome. So the question is variations of technique, and how can we, as a new society, come to some kind of agreement on what is the best technique, because I don't think we'll ever be able to get an agreement. Because each surgeon is different by definition of a surgeon, independence.
So, Namir, I'll go back to what Brant said. We need to track outcomes, because any reconstructive procedure is going to vary. If the outcomes are the same, whether it's 3 stitches or 2 stitches, I don't think makes a damn bit of difference. So it really comes down to tracking our outcomes and defining, thanks Joel, what are good outcomes. That's what we need to define, and if we can define that, then I don't know that we need to spend a lot of time going back into how many sutures we use and so forth. That's at least my response.
What about Steve or Vic or some others, or Brent?
Yeah, I agree. I mean, there's going to be slight variations, but the question is, does it alter the outcomes? And that takes looking at your own experience and then comparing it to others. Yeah.
All right, so that's an excellent question, and what we do in surgery or medicine in general is that we're only doing one of two things. We're either helping people live longer or we're helping them live better. And if we're not doing one of those two things, then we're really not doing our job. And so the question is that what type of outcomes are valuable and what type of outcomes are superficial? And so the same thing with these other variations. What variations are necessary, because they're variations in anatomy, so you have to adjust, and what variations are truly unnecessary. I don't know if I have the answer to that. It's almost a little bit about like what Judge Potter Stewart said about pornography. I can't define it, but I know when I see it. And same thing with what makes an experienced surgeon. Well, I can't define that, but I know it when I see it.
Well, that's very clear. You get to close out here, Blair.
I have a quick question for Raina. So, in your presentation, you talked about the disparity between therapeutic GIs and the surgeons. Can you give us just some insights into that conversation and how we may use that to be instructive for the future of AFS and how we all collaborate together? I know it's kind of throwing you on the spot here.
No, absolutely. And actually, tonight at the dinner, we're going to be spending a few minutes delving in a little bit into the methodology and how we can take it to the next step. So I guess I can give a brief answer and then a little bit more at dinner. So we use the RAND appropriateness methodology, and the reason why we chose that was it's a Delphi iterative, so we can understand what expert opinion is, but then get everyone at the table and really start to dissect where we're seeing differences. And really during that roundtable discussion is where we learned very valuable and eye-opening perspectives. So I'll show this later tonight, but after round 1, there was quite a bit of disagreement between the two groups. But then after we had our roundtable discussion, there was quite a bit of overlap and consensus. So I think the discussions really resonated and brought out the fact that everyone has similar perspectives. It's just that we may have been defining things differently or approaching the patient just a little bit differently. If that helps. Yeah.
Felice, we can't say no to you. Go ahead.
I appreciate that. One of the things that has become really sort of eye-opening for me, going to meetings with surgeons and gastroenterologists in the same room, has been that there's a sentiment from surgeons that gastroenterologists have a bias to not send patients for anti-reflux surgery, that they, for whatever reason, don't think to do it. It doesn't even come to be part of sort of their mindset to actually send patients. So I wanted to just hear from this panel whether or not you believe that that is actually true. And if that is true, in your opinion, why do you think we do it? And will this, if we're holding on to our patients too long, and we really should be sending them earlier, what can we do as a society to actually change that? Because what happens often is the surgeons go to their meetings and they talk amongst themselves, and the gastroenterologists go to their meetings and they talk amongst themselves, and we're never going to get beyond this. And if we're not doing the right thing, I think so much of it is because of anecdotal data, where perhaps it's not a perfect surgeon who's done an imperfect surgery on one of our patients, and we've seen the catastrophe, and we just can't get beyond that. So I'm just wondering whether or not you see that bias and what you believe the AFS can actually do to change that.
Stu, stand up a second. Stand up right next to Felice. This is the dichotomy: young, progressive, insightful, thinking about surgery. And then we have Stu. So there's a dichotomy. Yes, there are gastroenterologists that embrace surgery, but there are a whole host of them that read Stu Speckler's stuff.
But in defense of Dr. Speckler, now he's published some very interesting papers. He's done some of the major studies on anti-reflux surgery. So he has approached this, I think, in a very thoughtful way over the years. So we can make fun of him a little bit, but give him his credit.
He knows I like to tease him.
No, it's true. And because you're injured, I'm going to respond.
So Felice, Daniel Kahneman writes about this base rate neglect, something that is just a human thought process fallacy, that we neglect the base rate, we neglect the denominator. And so over the years, surgeons have neglected the denominator of the number of patients who are doing fantastic on PPIs, because I only see the patients who failed PPIs. And likewise, many gastroenterologists neglect the base rate of patients who do great after surgery and don't go back to see their gastroenterologist. So I think that there is a natural fallacy in our thought process that is part of the human condition. And we can work to overcome that, but it involves exactly what we're trying to do, and that is collaborate so that we both agree to overcome, at least in some conscious fashion, that known base rate neglect.
Thank you, Reg. I think we're going to call it at this point and move on to the section on esophageal motility and dysphagia.